Yeah, good evening, everyone. I welcome you all for this today's journal club. I think we have been doing for the last 2 years, and one journal is presented by the one of the Indian, I think, residents or junior faculty, and it is discussed by the one international faculty as well as one Indian faculty also. So we have so many eminent faculty members are here today. As a on board or off board also, so many people are here. They can discuss the same thing. And first thing I would like to request Dr. Tribhuvan to Panda to present any journal club. Then we have the discussion over this. I'll invite later the other speakers and the international speaker as well as international discussion as well as national discussion also. Welcome you all and over to you, Panda, Dr. Panda.
Okay. So, good evening, all. Can I share my screen now?
Yes, sir.
Okay, thank you.
Yeah, now we can see the screen.
Okay, sir. Thank you, sir. So, okay. So, is it full screen now?
Yes, sir. Please go ahead, sir.
Okay. So, good evening, all. So, on the outset, actually, I would like to thank actually the Indian Myeloma Academy group for giving me this opportunity to present this excellent, hot debated topic, I can say, that is treatment modality in high-risk smoldering multiple myeloma. So, actually, we have chosen the Journal Club article as daratumumab or active monitoring for high-risk smoldering multiple myeloma, which was actually recently published in the New England Journal of Medicine in December 2024 by Dimopoulos and Vincent Rajkumar et al. All of us know. And coming to the basic introductory smoldering multiple myeloma definition, as the term smoldering, it means actually, yes, at the right upper corner, you can see actually there is a picture actually. So there is basically there is smoke, but there is no flame. So the fire is actually brewing on. So smoldering actually at this particular stage. So whether you go for any intervention at this particular stage or you wait for the fire to come on, that is the multiple myeloma is actually the topic of discussion today. So it is actually a asymptomatic precursor state of plasma cell dyscrasia, and all patients of smoldering multiple myeloma actually they are not equal. So there are different risk stratification models depending upon which actually patients can be classified as either intermediate risk, low risk, or high risk smoldering multiple myeloma, and with subsequent variable rates of progression that we will discuss subsequently to active myeloma. Again, there is no approved therapy till date. So as we can see in this particular picture, initially there is monoclonal gammopathy of biological significance with accumulation of actually IGH translocation, like translocation 11, 14, 4, 14, and 14, 16, and subsequently as there occurs actually clonal evolution. So there occurs actually progression to early smoldering multiple myeloma with RAS mutation and again MYC translocation and other chromothripsis and genetic insults, and subsequently it transforms to active multiple myeloma. All of us should remember that actually this transition is usually dynamic and it is a non-linear progression. So there can be static progression per se, that is there is no change in the subclonal architecture. Basically, the clonal burden increases slowly, but there is no new evolving clones, or it can be spontaneous evolution with addition of new genetic inserts as smoldering multiple myeloma progresses to multiple myeloma, active multiple myeloma. So this is the basic definition, that is serum M protein more than 30 grams per deciliter or urinary M protein more than equal to 500 milligram per 24 hours with a clonal bone marrow plasma cells of around 10 to 60% in the refined biopsy without any end organ damage. That is no slim crack features. All of us know is defined as smoldering multiple myeloma. And most of the smoldering multiple myeloma, they usually progress in the first 5 years of diagnosis, that is at a rate of around 10% per year for the first 5 years and subsequently 3% per year. So coming to the this particular slide actually, so smoldering multiple myeloma is not a homogeneous entity. It is an heterogeneous entity and the treatment and the stratification has to be individualized. So it can be either low risk, it can be medium risk, it can be high risk depending upon many biochemical and clinical parameters. So as far as the clinical risk stratification is concerned, so initially what happened actually in 2007, the Spanish PETHIMA group actually proposed the risk stratification criteria incorporating the proportion of abnormal plasma cells by flow cytometry and immunoparesis, that is the level of actually that is reduction in the level of uninvolved immunoglobulins. And subsequently, there came the Mayo 2018 classification criteria, where actually they gave the typical 20-20 classification, that is more than equal to 2 gram per deciliter M protein, more than equal to 20 abnormal FLC ratio, and more than 20% bone marrow plasma cells. It defined the Mayo 2018 classification criteria. And again, in the International Myeloma Working Group 2020 criteria, they incorporated genomics in the form of actually translocation 414, 14, 16, and 1q gain, and deletion 13q, leading to actually 4 classification. That is the low risk, low intermediate risk, and the high risk smoldering multiple myeloma. So all these classifications basically neglected this genetic or molecular aspect, and this particular study actually was published recently in 2022, and they incorporated actually 214 patients, and the genetic subtypes of smoldering multiple myeloma has been subclassified into 6 different cluster classification, taking into account the single nucleotide variants, copy number variants, and the translocations. And they classified these smoldering multiple myeloma into intermediate, high risk, low risk, and low risk, as we can see in this particular tables. So coming to the rate of progression, as we can see in the PETHIMA, if no risk factor is present, you see the 5-year risk of progression is only 4%, as compared to if both the risk factors are present, the risk of progression at 5 years is around 72%. Can you imagine? So risk stratification is very important. Number 2, again in the Mayo 2018 22-20 classification, if there are 2 risk factors, that is 2 or more risk factors, then the 2-year rate of progression is around 50%, and the 5-year rate of progression is around 81%. So identifying the high risk smoldering multiple myeloma and hitting them hard before the fire comes out is now the key concept or clinical strategy where we can control the future end organ damage. So again, we have already discussed low risk, the 2-year rate of progression is 5%, intermediate 17%, high risk it is 46%, as we can see in this particular Kaplan-Meier curve. But yes, we have many risk stratification models. But what about the concordance and discordance rate, like in CML, UTOS, and Sokal score? So in this particular study, they have actually assessed the concordance rate of actually this risk stratification models. So Mayo risk model identified 38, 35, and 4 patients are low, medium, high risk respectively. Whereas Spanish patients, Spanish PETHIMA model, it classified 17, 22, and 38 patients as low, medium, and high risk respectively. So yes, there is a conflict. So there is a significant discordance, and this PETHIMA classified more patients into intermediate to high risk. So coming to the treatment modality, as far as the history is concerned, actually intervening in high risk smoldering multiple myeloma, the interest has been actually started in the late 19th decade. As we can see, initially with thalidomide, but yes, though there was a small PFS benefit with thalidomide versus observation, but the side effect was actually side effect and tolerance profile was very poor as compared to the low benefit. So again, the treatment was fine-tuned to lenalidomide. So lenalidomide, yes, it again prolonged the actually progression-free survival. We can see from this Curidex trial and from this paper published in JCO in 2019. And subsequently came the interest of actually again intensifying the therapy with daratumumab. And now the area of discussion or topic of discussion today will be Aquilia trial. So the concept of Aquilia trial actually came with this particular background, and the dosing schedule was again taken from the phase 2 Centrus trial, where actually they have given this IV daratumumab, intravenous daratumumab monotherapy, and in a 3 dose dense schedule. And they have actually found that patients with high dose intense dosing, they actually gained the maximal benefit. So this particular dose intensity was followed with subcutaneous daratumumab for the first time in this particular Aquilia study. So this was a open label randomized phase 3 unblinded. Blinding was not done. Study performed between actually 2017 to 19 with patient enrollment in 124 sites in 23 countries, and more than 18 years of age, with confirmed smoldering multiple myeloma diagnosis within last 5 years with a good performance score, with a clonal bone marrow plasma cells more than equal to 10%, with any of the following high risk factors were included for the study. That is more than 10% plasma cells with M protein of more than equal to 30 grams per deciliter, or IgA smoldering multiple myeloma, immunoparesis with reduction of the two uninvolved IgG isotypes, then FLC ratio more than equal to 8 and less than 100, and clonal bone marrow plasma cells more than 50% to less than 60%. So basically, they have incorporated the criteria from the PETHIMA, from few from Mayo, and the SLIM criteria. So all patients were required to have actually either whole body low dose CT or PET CT and MRI imaging during screening. So patients were randomized in a 1:1 fashion. Total 390 patients were enrolled, and daratumumab monotherapy with 1800 milligrams subcutaneous every weekly for 2 cycles, and then again every 2 weekly from cycle 3 to cycle 4, and then every 4 weekly for a total of 36 months. 39 cycles were given, and again other arm were actively monitored till actually confirmed disease progression or 36 months. And efficacy follow-up was done by SLIM criteria, and survival follow-up every 6 months until the end of the study. So the primary endpoint of this particular study was PFS by independent review committee as per the International Myeloma Working Group SLIM criteria, and the secondary endpoints was overall response rate, time to first line treatment for multiple myeloma, PFS and first line treatment when patients actually progress to multiple myeloma, and overall survival. So coming to the statistical methods, actually time to event endpoints were compared between the groups with use of stratified log rank test. Hazard ratio and 95% confidence interval were estimated with Cox proportional hazard regression model, and landmark estimates and 95% confidence interval were derived from Kaplan-Meier method, and data for response endpoints were compared between groups by stratified Cochrane-Mantel test. So yes, coming to the baseline demographic and clinical characteristics, as we can see, the median age was around 194 patients were enrolled in the daratumumab arm, and 196 patients were enrolled in the active monitoring arm. And the median age was perfectly balanced, was around 63 years in daratumumab arm and 64 years in the active monitoring arm. Again, around 28% of the patients had actually IgA multiple myeloma. Per se, it is a high-risk smoldering multiple myeloma subset in daratumumab arm, and around 21% of the patients, they had actually IgA myeloma in the observation arm. Most of the patients, that is around 60% of the patients, they had actually 10 to 20% bone marrow clonal plasma cell burden, and 9.8% of the patients had actually more than 40% in the daratumumab arm, and 14.3% had actually more than 40% in the active monitoring arm as far as the plasma cell clonal burden is concerned. Then coming to the risk factors, that is high risk factors, more than 3 high risk factors was present in around 20% of the patients, that is 40 patients out of 194 in daratumumab arm, and again 20 patients, 20% of the patients in the active monitoring arm. So more than equal to 1 high-risk cytogenetic abnormality basically was found in around 17% of the patients, that is deletion 17p, 414, 14, 16 in the daratumumab arm, and 12% of the patients in the active monitoring arm. So again, they have actually reclassified the patient cohort into Mayo 2018 risk stratification model actually. So most of the patients, around 40% of the patients were actually high risk, and the rest of the 60% of the patients, they were low to intermediate Mayo risk stratification criteria is concerned. So we have to remember that most of the patients were actually Mayo low to intermediate risk group. So coming to the primary endpoint, so the median follow-up was around 65.2 months. As we can see from this particular Kaplan-Meier curve, there is a significant actually difference in the progression-free survival between daratumumab arm and the active monitoring arm. So the 2-year overall progression-free survival was around 79.9% for daratumumab arm versus 63.3% in the observation arm. So basically, they have given daratumumab for 36 months, but the PFS benefit actually lasted beyond 36 months, that is till 5 years also. So the 5-year progression-free survival was 63.1% for daratumumab arm and 40.8% for the active monitoring group. So the median PFS was not reached for the daratumumab arm, and it was 41.5 months for the active monitoring group. So as we can see, with a p-value of less than 0.001, the hazard ratio was 0.49. So there was a significant reduction in the risk of progression to multiple myeloma or death by 51% as far as daratumumab is concerned compared to active monitoring. Again, at the right hand table, as you can see in this particular table, the PFS event, that is either disease progression or death, was happened in 67 patients in the daratumumab arm and 99 patients in the active monitoring arm. So disease progression was documented in 62 patients and 94 patients, that is in the DARA and active monitoring arm. So very important is actually disease progression was documented either by CRAB criteria or by SLIM criteria. So none of the patients, as we can see in the active monitoring arm, actually developed either hypercalcemia or renal insufficiency. Point to be noted actually. So even if they are not on treatment, actually none of them developed any renal impairment. Again, as far as anemia is concerned, that is they have defined anemia as reduction in the reduction of baseline hemoglobin of around 2 gram per deciliter. So around 3.2% of the patients in the daratumumab arm and 14.9% of the patients in the observation arm, they had actually progressive anemia. And again, bone disease was found in 16.1% of the cases and 19.1% of the cases in DARA and active monitoring cohort respectively. Again, in bone disease, none of the patients, they had actually fractures, all were asymptomatic bone disease. Okay. Then coming to the SLIM criteria, the clonal plasma cell burden more than 60% was fulfilled in 8.1% of the patients in daratumumab arm and 17% of the patients in the active monitoring. Again, serum FLC more than 100 was encountered in 53.2% of the patients in the daratumumab arm and 35.1% of the patients in the observation arm. And the focal lesions by MRI on regular follow-up was found in around 20% of the patients in both the arms. So this is the basic flow chart. As we can see, 390 patients underwent randomization, 193 received treatment in DARA, 196 active monitoring. So 66 patients from the DARA arm, they basically discontinued treatment. So 42 had actually progressive disease, 13 had an adverse event, and 5 withdrew. And again, 116 patients in the active monitoring patients, they had actually discontinued active monitoring because 82 had actually progressive disease and 1 had an adverse event and 22 withdraw and 4 died. So finally, 127 patients, they completed 39 cycles of treatment of DARA and 80 patients, they completed 36 months of active monitoring. So coming to the time to first line treatment for multiple myeloma, as we can see in this particular image, the first line treatment for multiple myeloma was initiated by 33.2%. That is 64 patients out of 193 in the DARA group versus 53.6%, that is 105 patients in the active monitoring group. So DARA prolonged the time to first line treatment for multiple myeloma versus active monitoring. So as you can see in this particular image, the median PFS was around 50.2 months for active monitoring group, and for daratumumab actually it was not reached. Again, coming to the PFS2, that is when patients progressed, when they again challenged by salvage chemo. So daratumumab again had a particular great response as compared to active monitoring is concerned. So at 5 years, the 5-year PFS was around 85.9% for the daratumumab arm compared to 78% in the active monitoring arm, with a hazard ratio of 0.58. Basically, this p-value is not available in this particular graph. And again, so PFS2 is also improved and no adverse impact of DARA therapy on subsequent outcomes was seen. But again, there is also, this data has to be interpreted with a pinch of salt, because actually most of the patients, those who have actually progressed, they received actually VRD, Lendex or Cybordi, and only 25% of the patients in the DARA group and 33.3% of the patients in the active monitoring group, they received actually anti-CD38 regimens at relapse. Okay, so there is a significant clinical heterogeneity as far as the real world treatment pattern is concerned in this particular trial when patients actually progressed in both the arms. So DARA though improved actually PFS on first line treatment for multiple myeloma versus active monitoring, and doesn't appear to be impair the latter treatment for multiple myeloma. Again, coming to overall survival, there was a overall survival benefit, and this overall survival benefit has to be again judiciously interpreted, because number one, this study was not powered for this overall survival analysis. Number two, as we can see, actually we have already discussed, there is a significant treatment heterogeneity of the patients on relapse actually. And again, the long-term overall survival data is yet to mature. This will be very interesting to see the long-term overall survival data of this particular trial on follow. So on daratumab arm, the 5-year overall survival was around 93%, and it was 86.9% in the active monitoring arm. So early intervention with fixed duration daratumab extended overall survival versus active monitoring as per this particular trial. Again, coming to the number of deaths, there were around 15 days, 7.7% of the patients in the daratumab arm compared to 13.3% of the patients in the active monitoring arm. And again, as far as the death cause is concerned, due to disease progression, 3 patients died in the DARA arm and 9 patients died in the active monitoring arm. Coming to the safety profile, basically, daratumab had a good safety profile, and there is a 10% absolute high risk of grade 3 to 4 adverse events in the DARA arm. So, any grade treatment emergent adverse events were seen in around 96% and 82% of the patients in DARA and active monitoring arm. Grade 3 to 4 treatment emergent adverse events was seen in 40% and 30% respectively in DARA and monitoring arm. And again, the most common grade 3 or 4 treatment emergent adverse events where hypertension was seen in 5.7% and 4.6%, which was manageable, and the serious toxicity, that is pneumonia, was seen in around 3.6% and 0.5% of the patients respectively, and grade 5 toxicity, that is death, was seen in around 2 and 4 patients respectively in the DARA and active monitoring group. Then coming to the dose modification, basically 90% of the patients, 46% of the patients, 90 patients, they had actually required dose modifications due to treatment emergent adverse events. And since it was actually during the COVID pandemic time period, so serious COVID-19 treatment emergent adverse events were seen in around 2.6% of the patients, compared to 0.5% of the patients, only 1 patient in DARA and active monitoring group respectively. So this risk of infection and the treatment emergent adverse events like pneumonia, COVID infection, and other viral infections and fungal infection has to be taken with a pinch of salt as far as a developing country like India is concerned, keeping in mind our infectious burden and institutional infectious policy. So one of the most important thing for this particular trial, actually, they have documented the patient-reported outcome data. So the EORTC quality of life questionnaire global health status score was documented periodically in a longitudinal manner from baseline, week 12, week 24, week 60, and week 112. And as we can see, the quality of life was significantly preserved or maintained in the daratumab arm as compared to active monitoring throughout the treatment period. So DARA treatment didn't negatively impact the patient-reported health-related quality of life. So coming to the conclusion, so in this large phase 3 trial, in a well-defined population with high-risk smoldering multiple myeloma, daratumab subcutaneous monotherapy for 36 months, it demonstrated a statistically significant PFS benefit versus active monitoring with a hazard ratio of around 0.49, that is 51% reduction in the risk of progression or death. And the greatest PFS benefit with DARA was observed among the patients with high-risk smoldering multiple myeloma, retrospectively identified by the Mayo 2018 criteria. So around 40% of the patients, they had actually Mayo high-risk criteria among all the patients included in this particular cohort, and they derived actually maximal benefit with a hazard ratio of 0.36, just you see. And daratumab prolonged the PFS on first-line treatment for multiple myeloma with hazard ratio of 0.58, and it demonstrated a favorable safety profile with a low rate of treatment discontinuation due to treatment emergent adverse events, and there was no detrimental adverse events to health-related quality of life, with a trend towards improvement with DARA, and DARA extended overall survival also in this particular study, as we have already discussed. So actually, it strongly favored early intervention with DARA monotherapy. in patients with high-risk smoldering multiple myeloma, representing an opportunity to delay or avoid the end organ damage and progression to active multiple myeloma and to extend the overall survival. So coming to the critical appraisal of this particular study, basically coming to the strength of this particular study, it is one of the largest trial as far as the smoldering multiple myeloma is concerned till date. It has shown actually there is a significant PFS benefit and there is also a OS benefit with early intervention with high risk smoldering multiple myeloma with daratumumab, and patient reported outcome data is also available. Quality of life is maintained, and it provided actually a foundation for the operational cure, a vision for the operational cure for multiple myeloma in future with early intervention. So coming to the limitations, basically this particular study was not blinded. There can be some bias basically. So again, coming to the imaging modality, they have actually used whole body low dose CT and MRI and PET CT. But in smoldering multiple myeloma, it has been seen that diffusion weighted full body MRI can upstage the patients with identification of more number of lytic lesions, and they have not done actually in this particular study. So maybe there is some active multiple myeloma cases which we have actually maybe missed in this particular study, leading to under treatment. Again, coming to the high risk definition criteria, few myo high risk actually in this particular study. Actually, most of the patients, they were myo intermediate or low risk as far as the myo risk stratification model is concerned. So again, over treatment to some of the low or intermediate risk patients may be a concern as far as the heterogeneity in the risk stratification criteria is concerned. Again, genetics has not been incorporated in detail, and there is also no availability of MRD data, and the PFS as a primary endpoint is again is expected to get a PFS benefit when you compare any observation, any treatment modality with observation as a standard of care that we have already seen with thalidomide, lenalidomide, and again now daratumumab and many other agents also. And the OS was also not powered adequately. And again, the treatment and progression was also it was heterogeneous. And again, as far as our concern is concerned, actually pharmacoeconomics like cost and availability and many other issues also come into play. So I would like to know actually the practice of all my esteemed teachers here. Actually, would it change our practice in near future? So how to proceed basically? Should we wait for the fire to come or intervene now? How to choose in our actually real world practice? So the story doesn't actually end here. Actually, the field is evolving. So now they have actually many trials. There are many trials which are actually now intensifying further as far as the treatment modality of high risk multiple myeloma is concerned. So in this particular HOVON 147 criteria, they have actually evaluated KRD with Lendex in high risk smoldering multiple myeloma. In the DETER smoldering multiple myeloma trial, Dara Lendex was compared with Lendex, and in the ETHAC trial, isatuximab with Lendex was compared with Lendex in high-risk smoldering multiple myeloma in a phase 3 manner. And again, in the ASCENT trial, as we can see, this was the first trial which actually evaluated the role of quads like DARA KRD. DARA KRD in high-risk smoldering multiple myeloma. And again, the curative strategy, that is the GEM-CISAR trial, it has also a aggressive approach of using KRD induction followed by autologous stem cell transplant, 2 cycle of KRD consolidation, and again maintenance with Lendex. And again, now it is the era of actually bispecifics. So teclistamab, talquetamab in combination with daratumumab for the treatment of high-risk smoldering multiple myeloma as part of the phase 2 REVIVE trial is also ongoing. So now the challenge is actually how to choose a patient carefully. So over treatment and under treatment, these are the main two spectrum of actually bias and challenges. So keeping in mind all these factors, balancing the toxicity and preventing the selection of the resistant clones, and yes, all of us know it is non-curative, just we have to control. But yes, maybe in near future with availability of MRD data and genomics, actually we can cure this entity with early intervention. So all this should be taken into account. So this is the actually operational guideline till now as far as the smoldering multiple myeloma treatment modality is concerned. So any patient, if any myeloma defining events like CRAB features more than equal to 60% plasma cells, FLC more than equal to 100 or MRI more than equal to 1 focal lesions, then treat as myeloma. Then if there is no myeloma defining events, we have already discussed, then it is smoldering multiple myeloma. So if it is high risk smoldering multiple myeloma, the median time to progression is 2 years. So the crux lies here actually the risk stratification model, which risk stratification model you are using, and whether you are actually incorporating the genomics and the molecular data and everything. So it will evolve as time passes. So high risk smoldering multiple myeloma or evolving smoldering multiple myeloma, either you can go for a clinical trial or early therapy with daratumumab or lenalidomide for 3 years. It's advocated. Basically, it is the judgment of the physician and the patient also, keeping in mind everything whether to offer this treatment modality or not. But yes, in near future, when actually we will get the FDA approval or EMA approval for this DARA or LEN for this aggressive disease entity, yes, we have to actually consider this as the treatment modality of choice. And as far as the intermediate and low risk patients, yes, observation is the standard of care as of now. So thank you so much. Thank you.
Yeah, thank you very much for a wonderful discussion, Dr. Vikram Panda. Really, you have enlightened us in all the issues actually, from stratification to treatment part, and at the same time, you have compared with the single agent LEN, Daratumumab, and LEN and DARA also. I think really you have discussed very nicely. Thank you once again for this presentation and detailed discussion. Now I would like to request our international faculty, Dr. Ajay P. Nupta, is at Emory University and School of Medicine, Atlanta, Georgia. So welcome you, sir, for this discussion. And next, I would like to request Dr. Pravash Mishra from Amrita Hospital, sir, Faridabad. So he is from international discussant. I think now we can go for the discussion. Anybody can ask any questions in this one. If any questions which pop up in the chat box also, we'll ask that answer. So I think now we open this general for the discussion. Comments from you both of you, sir, first. Then anybody can ask any questions. We'll ask you in that. Thank you, sir.
Thank you for having me. So this is a very comprehensive review, and the timing is so perfect. When you look at the interventions in the smoldering myeloma space, interventions have always worked. So this is a space where there was a lot of heterogeneity in terms of identifying who that high-risk patient population is. Go back to the last slide of what Dr. Panda had shown, where the time to progression of 2 years is considered as high risk. Whenever you look at a study, the biggest, my eyes goes first to the control arm. If you look at the control arm, what's the median PFS or the median time to progression in that control arm? That helps you understand what the study population is all about. Here, 60% of the patients have progressed at the 24th month in the control arm. So that group is the one that probably needs an intervention. So we need a lot of refining that the high-risk stratification of how to identify this patient population. But my take-home message is the low and the intermediate risk groups, when you look at the forest plot in the supplement, they don't get as much of a benefit as the hazard ratios are crossing 1, and the hazard ratio is 0.58 and 0.7. In fact, for this, the group that got benefited the most with the hazard ratio 0.36 is the high-risk group, which contributed to approximately 40% of the patients. So identifying who that patient population is the most important part. The next most important part is intervention has helped from them to prevent from progression to a myeloma. So if you take those two, what is the intervention? We always can refine that intervention. How do you define that high-risk patient? And more of what we're looking at here is a tumor burden as a mode for us to talk about the high-risk patient population. We'll take the analogy from myeloma. We used to use, I don't know how many of you remember the Jury-Salmon staging that is purely based on the tumor burden. Never took any of the host factors or the biological factors into consideration. You only took the tumor factors into consideration in terms of a tumor burden and staged them. And it never panned out to be the best model that one can use. So here in smoldering myeloma, we exactly do that. We look at the size and the magnitude of the paraprotein. We look at the amount of the plasma cell burden, but we never take into the real biology of the disease into consideration to group them. And probably the future is looking forward for a strategy or a stratification where one can risk stratify these patients into low risk, intermediate, and high risk based on not only just the the tumor factors, but also taking the host factors into consideration.
Pravas, you can give your comments.
Oh, okay, fine. Thank you, Dr. Ajay. That was wonderful. I think you're right. What we understand from this uh, study is that daratumumab does provide a very clear progression-free benefit across all age groups, particularly for the high-risk subgroups. They even, I think, in the supplementary analysis, they even looked at weight and age, impaired renal function. Probably those who are poor performance status don't do as well with this. The way I would look at it in this study, like let's say, what do I take from this study, is that we are trying to achieve this concept of operational cure. I mean, we are looking at trying. For some reason, myeloma is not very amenable to cure, but uh, for this smoldering myeloma, so we got the Aquila trial. Then we have to look at various. Are there any other interventions which can achieve the similar degree of progression-free survival or overall survival with a lesser cost? And finally, are we able to cure myeloma? So Dr. Panda did touch upon the QREDX trial. There's the ECOG trial as well. I think the ECOG trial had done lenalidomide 25 mg till progression. They also showed a progression-free survival, but they were not able to show an overall survival. The QREDX, which used lenalidomide and dexamethasone, has also shown a very clear progression-free survival. Perhaps if you look at them separately, the hazard ratio for QREDX was 0.24, so probably doing better than even daratumumab. But the overall survival was also there. That was the first time that they actually showed an overall survival. The difference between Lendex and daratumumab, from the two studies that one can gather, is that the Lendex achieved whatever overall survival it could much later. So daratumumab does that change earlier. Now, whether that earlier change actually translates into long-term benefit, perhaps that remains to be seen. And again, if you look at the data which Dr. Panda showed, the overall survival, even for the Lendex and for the DARA, the hazard ratio, the CI, the CI is just between 0.27 to 0.9. It is almost just about crossing 1. So I'm not very, it's just about touching that statistical significance. So perhaps as you keep following up these patients much longer over a period of time, one might see there might see a difference in that overall survival. The other thing he did mention was that many of these trials have used different definitions for high-risk smoldering myeloma. We are now following the IMWG or the Mayo. The IMWG does use certain other aspects like the FISH. Cytogenetics have been used. And finally, the way I mentioned is that I look at it as an operational cure. So, what is operational cure? Like maybe you can't completely eradicate the complete clone, but keep the disease quiescent to a degree that the person then remains in a chronic state. They remain perhaps even treatment free. They are not on any medications for a long period of time. And again, here perhaps it would be important to start measuring MRD. So this study, they did not study MRD, but perhaps MRD then becomes important, particularly in these studies also, how you go on following up these patients. So it could be with NGS, it could be with next generation flow or PET-CT. I prefer PET-CT in a follow-up, especially because it gives us information for extramedullary disease as well. That somehow becomes much more important. I have had patients where on follow-up, the bone marrow is absolutely all right, and the patient just ends up with some kind of an extramedullary disease. Perhaps PET-CT would do better than MRI there. In a smoldering myeloma, yes, whole body MRI, yearly MRI, I think that has been done, and that could perhaps be one way of looking at these patients and selecting those cases who might require treatment earlier. And what else? So I think the other thing is the other concern that comes up when people are giving lenalidomide, dexamethasone, or any of these medications early on in smoldering myeloma is that are we going to select out some patients who are going to be resistant? So later on, if they progress, are they already resistant? Do they have resistant clones? Would you be able to treat them safer? I think from the LENDEX study, we did come to know that there is no appearance of any resistant disease later. And if these people do progress, you can treat them with the same drugs that we are using for multiple myeloma. So I think you hit hard, hit early. Early exposure to therapy will probably not give any kind of resistance later. How long to stay in MRD negative state to actually define that you have actually achieved an operational cure? I think that only time will tell. We don't know that answer so far. And which approach would be best to achieve this, whether use daratumumab or lenalidomide. Now coming again, we have got CAR-T, so no discussion nowadays can stop without CAR-T. And so we do have, I think that was a CAR PRISM study which had been put up in ASH. So they studied the use of Silta in patients with smoldering myeloma. And in those high-risk patients, they do have some benefit. So perhaps even without giving any treatment, CAR-T can give some benefit. So in the future, you might just have high-risk smoldering myeloma, which you can give CAR-T. So who knows how it goes on further.
So thank you, sir, for wonderful, I think, experience as well as illustration of smoldering multiple myeloma. It really described very well, both of you. I think, as you know, this risk stratification is most important. Which patient needs these high-end therapies? Because I think the most important things I've mentioned, Dr. Raghu also. And only problem is, I think, as you said, once they have received the DARA, once they progress on that, they may not again respond to DARA. I think that's the only one hitch here. So in this setup, do we have any other therapies like teclistamab? And do you advise any other thing other than this DARA? Like Ajay,
So great question. So historically, what we've talked about was, so this is a 3-year period of what we're using for daratumumab as a small in the smoldering myeloma patient population. So patients are exposed to daratumumab even though even though they have not progressed. So the data is limited in the setting of would the outcomes be the same in patients who have the DARA exposure if they're treated with the same agent? So unfortunately, that's a gap still existing in the literature. There is some preliminary data showing that DARA exposure patients may not do as well as the patients who are DARA naive. In fact, they do as close to as DARA refractory setting. However, we don't have any data in the smoldering myeloma space at this point of time. But in myeloma, there are few studies that were, because if you look at the treatment history, we started using database combinations probably in the outpatient setting in the last 5 years. The number of people that progress is less than 5% during that time. So you expect quadruplets, 4% of the patients progress per year. So close to the earliest people who started treating DARA in the newly diagnosed setting is in the range of around 15 to 16%. So the people who started in the last 1 or 2 years, it probably is in the less than 10% of the patients have progressed. So it brings the epidemiological picture into the view. It's a small portion of patients that you're looking and trying to make large conclusions, which is not fair at this point of time. So I would give all the benefit to using daratumumab as a retreatment if the patient has a period of time where the patient has not been treated with daratumumab. The only patient that I would not be using as a retreatment is patient who's progressing while receiving daratumumab.
Good evening, sir. Actually, sir, I have one question. So basically, thanks for your comments, excellent comments. So basically, do we feel actually exposing patients to daratumumab while they are on smoldering multiple myeloma can hamper the further trial eligibility for patients in their future when they develop actually active multiple myeloma? Because there are many trials who actually say patients should be DARA naive or something like that. If we give them exposure of DARA earlier, so can it hamper their subsequent eligibility for enrollment in clinical trials?
It's a great question, Dr. Panda. So this was a question that we posed to the regulatory agencies as well. So you have to look at the consequences of what we do. So the same thing went on with the lenalidomide trials, the same thing went on with the daratumumab. So while these trials are ongoing, we went to FDA to talk exactly about the same aspect. What FDA gave a recommendation to the sponsor. Again, it's up to the sponsor to decide whether they want to do this. They do not want to change anything of the previously planned trials, but have a subset, a group of patients who have received daratumumab previously. So the future trials in the newly diagnosed setting might include a subset that would have said, these are the patients. This is meant for those patients who had smoldering myeloma and had been previously exposed to daratumumab.
Thank you.
Yeah. Thank you, sir. I think Dr. Pankaj, sir, I think you are the more conservative man in India now. So what is your opinion? Always and you'll stay always and with the patient and financial issues are most important in Indian context. So what is your take on this one, sir?
No, I have more of a philosophical kind of a view that, why we diagnose smoldering is because we really do not know who are the patients who are actually going to develop active myeloma and who are the MGUS-like situation. So probably in future, as we get more medicines and the medicines which are kind of without much adverse events, once those come, I think we are going to remove this term smoldering myeloma in future. So we will have MGUS and we will have active myeloma. So till that time, I think we are continue to see some of the trials with various medications or combination of medicines, like what Dr. Panda has presented, and including CAR T cell kind of a trial. But the real challenge again would be that who are the patients who would continue to behave like an MGUS and who are going to develop active myeloma in future. So that's my view. Thank you.
Any other comments or any other questions from any in chat box? No questions, Alexis. Thanks. So no questions popped up in this one, sir. Shall
I'll make
we?
a comment on the
Yeah, please,
overall
please.
survival.
Yes, sir.
So these studies should not be discounted for anything. At least this I have an epidemiology background, so I'll be talking about from an epidemiological standpoint. These are the studies that are supposed to show an overall survival benefit. The reason is when the contrarian view that we always get is we don't have an overall survival benefit in the active myeloma. How would you expect to see an overall survival benefit in the smoldering myeloma space? The patients who are enrolled on the trials have already passed through a lot of screening, and the fit person with the best organ functions are the ones in the trial. You don't expect to see any of those. If you look back into the UK data, where most patients go on to the clinical trials, they were able to show the first 1 month mortality is in the range of around 5%. So by using any of these smoldering myeloma studies, you're capturing that rate of those people who are falling even before they went on to a trial in the active space. So that's the same reason I feel that the Quiridex, the E3 AO6, as well as this trial, the longer the longer the time that we follow up, we will be seeing those survival advantages over time. And this is a huge natural history experiment.
Right. Thank you, Ajay. I think in this, because we are running short of time, I think we hand over to
Dr. Sumit, sir, now. Yeah. Dr. Sumit, over to you.
So am I audible?
Yeah.
Are my slides visible?
No, sir, still not.
Yeah, I'll just try once again. Is my slide visible, Neerav?
Yes.
Yes, sir.
Thank you for that interesting discussion. So we'll come down to the Eagle Eye competition for this month. The Journal Scan article on which Eagle Eye entries were invited was Mode of Progression in Smoldering Multiple Myeloma, a study of 406 patients. So just to brief the process to those who are new to this, a recently published article on plasma cell dysplasias is selected. A commentary of less than 175 words before deadline is invited. Anyone, irrespective of designation, is invited. who can write in a specific commentary on this. And the best commentary is selected by a team of blinded reviewers. And whosoever is the winner presents a journal scan, gets a certificate of image credit hour along with image lifetime membership. The intent is that all students as well as faculty should classes in this area. They should learn how to critical appraisal, refine the art of scanning an article, which will generate results from a country. And similarly, it will give students as well as early career faculty an opportunity to present in front of a national and international audience, and thereby generate inter-institutional competition. There are multiple parameters on which this is analyzed based on a summary, the title, the abstract representation, author's core assumptions, critical word count, errors in author's interpretations on facts, some ideas may be over or underemphasized, the approaches and research methods, the statistical methods, the references, and coming down to a final score. It is important to stick to the word limit, being succinct and still convey the critical analysis, and to concentrate on the methodology and statistics, which is at times underemphasized. I would like to thank our reviewers, Dr. Pravas Mishra sir and Dr. Sadashiv sir, who helped us in reviewing this time's Eagle Eye entries. I'm happy to announce that the winner is Dr. Atish Saraswat, who is pursuing ND pathology at AFMC Pune. I would hereby request Meera from Mice Ideas to play the recorded commentary which we have from Dr. Atish Saraswat. Meera and Priyanshi, can you do the needful?
Greetings of the day, everyone. I, Dr. Atish, will be presenting the journal scan section of this month's image event, for which I would like to thank the academic committee for providing me with this wonderful opportunity. I'll be presenting the article under the following headings. The article Mode of Progression in Smoldering Multiple Myeloma, a study of 406 patients, was published in Jan 2024 by Abdullah et al. In the Blood Cancer Journal. Smoldering multiple myeloma is an asymptomatic clonal plasma cell disorder that lies between MGUS and multiple myeloma. It is characterized by specific lab parameters and has an incidence of around 0.9 per 100,000 in US, and its prevalence increases with age. The disease is heterogeneous in nature, and in terms of progression, two risk stratification systems are most commonly employed, the Mayo model and the IMWG model. Management of smoldering multiple myeloma is ever changing, with regular clinical trials being done for the same. A brief look into the pathophysiology. The disease starts from the post-germinal center B cell undergoing initial events like IgH translocation or hyperdiploidy. At one end of the spectrum is MGUS, while on the other end is plasma cell leukemia. This progression is carried under secondary genetic events, and each disease entity in this spectrum has a definite diagnostic criteria which needs to be fulfilled. The aims of this study were to evaluate the proportion of patients with smoldering multiple myeloma who are considered high risk at time of diagnosis, proportion of patients with high risk smoldering multiple myeloma who receive early treatment, and proportion of patients with high risk smoldering multiple myeloma who progress to multiple myeloma among those who receive early treatment versus those who are managed with observation alone. It also aims to describe the myeloma defining events at the time of progression and the clinical presentations that led to diagnosis of active multiple myeloma. It is a retrospective study from 2nd August 2013 to 24th Feb 2022 carried out at Mayo Clinic, Rochester. August 2013 was chosen as the cutoff date because it was the date of initial publication of results of Quiridex trial. Smoldering multiple myeloma was defined as presence of one or more than one of the following: serum M protein more than equal to 3 gram per deciliter, urinary M protein more than equal to 500 milligram per 24 hours, and more than equal to 10% bone marrow plasma cells without the slim crab criteria. Slim crab criteria has been enumerated. Risk stratification was done using Mayo system and not the IMWG model due to lack of cytogenetic data for all the patients. The cytogenetics included in IMWG model were translocation 414, translocation 1416, gain of chromosome 1q, deletion 13q, or monosomy 13. Myeloma defining events were categorized as follows: bone lesions, anemia, hypercalcemia, renal insufficiency, MRI marrow lesions, bone marrow plasma cell, or free light chain ratio criteria only. Presentations leading to multiple myeloma diagnosis included surveillance labs, surveillance imaging, both surveillance labs or imaging with symptoms, workup due to lab changes, workup for unrelated medical conditions, bone pain, hospitalization due to multiple myeloma complications or symptoms, and lastly, unknown. JMP statistical software was used for analysis, and Kaplan-Meier analysis was done for time to progression, progression-free survival, and overall survival. Coming to results, the sample size was of 406 patients, with median age being 66 years. Males were more than females, and 22% of the patients were at high risk, 29% were intermediate risk, 27% were at low risk, and 22% were placed in unknown risk column. In the limited cytogenetics data, the authors had 25 patients show translocation 414, 9 show translocation 1416, 97 had either deletion 13q or monosomy 13, and 74 patients showed gain of chromosome 1q. In terms of disease progression, 39% patients progressed to multiple myeloma by last follow-up, and 10% patients died by last follow-up. The average frequency of follow-up being 1 to 18 months, and the same as per risk stratification of the patients has been tabulated. In terms of management, patients under observation were 90 of low risk, 101 of intermediate risk, 71 of high risk, and 83 of unknown risk. The others were started with different approaches of management. Myeloma defining events by risk group, bone lesions were the most common amongst all risk group. And in terms of presentations leading to multiple myeloma diagnosis, surveillance labs were the most common. That is, diagnosis was made on scheduled surveillance lab testing satisfying the diagnostic criteria. The study had the following strengths, that is, it had a large sample size and it reflects actual clinical practice. Detailed risk stratification was employed, and a comprehensive analysis of myeloma defining events, clinical presentations, and treatment approaches have been described, along with focus on high-risk smoldering multiple myeloma patients. On the other hand, the limitations include that it is a retrospective study, so it can have selection bias and missing data, along with variability in follow-up data and incomplete cytogenetic data, imaging data, and treatment outcomes. Also, since it is a single-center study, so it has limited generalizability. In terms of practical implications of this study, we can say that it shows personalized risk stratification, shared decision making, which empowers patients to understand the risk and benefits of the early intervention, awareness of end organ damage among the clinicians, and guidance for future clinical trials. The overall contribution of this paper towards Indian hematology practice can be summarized as practical risk stratification for Indian settings, as the model is resource friendly and can be widely implemented in India, unlike the IMWG cytogenetic based classification, which is constrained by limited access to FISH and NGS. Reinforcement of early intervention in high risk smoldering multiple myeloma, as many hematologists prefer a wait and watch approach. However, this study highlights that 72% of such patients progress to multiple myeloma despite regular monitoring. Hence, it strengthens the case for early intervention in select high-risk patients. A need for standardized surveillance protocol as a structured follow-up strategy, including 3 monthly biochemical surveillance and periodic imaging. Strong emphasis on bone lesions as myeloma defining events, underscoring the need for early imaging with whole body low dose CT or MRI in patients at risk. However, the major gap of this study includes what triggers the biological shift, and this forms the basis of future clinical trials as well. These two articles summarize the underlying events, which include both the tumor microenvironment as well as the external events, and can be used as a baseline for further research and clinical trials. Thank you.
Thank you, Dr. Afish, for a nice presentation. So, Neerav, is my slide visible?
Yes, sir.
So, the Journal Club article for the next month, that is on 27 March 2025, the theme is MGUS, and the Journal Club article is Comparison of Progression Risk of MGUS by Method Detection. It's published last month. And an interesting journal scan article for Eagle Eye for next month is VITT-like monoclonal gammopathy of thrombotic significance. And this will be very interesting for our students and young faculty to read. Thank you. And over to Dr. Nitin Yashas for the quiz.
Thank you to the image organizers, as always, Dr. Pankaj sir, Dr. Uday, Dr. Sumit, for this opportunity, and very, very interesting journal club and journal scans that we discussed, and very insightful. The rules for the quiz, as you would all know, always, next slide, is that you would have 5 questions, 30 seconds, and it's very, very important that you have to be fast and you have to be accurate. The new Formula One season is starting, and that's what we expect even the quizzers to be very fast, very accurate, to get the pole position and to win as such. So it's going to be based predominantly on the smoldering myeloma. So if you're ready, you'll get 30 seconds for each question. Coming up, your first question being very, very simple. It's not who coined the term multiple myeloma. I'm sorry, I think there is a mistake here. I'm sorry. Can we just roll back, please? The organizers, I don't think this is the right question.
Yes, sir.
This doesn't seem to be the correct
No,
this
I
thing.
think when you share the slide, I open and check, sir, on this first question.
Just 1 minute, please. No, that is not the one. Even the one which I've shared you is different completely.
You can share, Nitin, from your own screen.
Yeah, sure. But
Nitin, sir, can you see the screen?
yeah, this is
Please.
indeed the first question. Which is the possible first described case of myeloma?
Sarah Newberry.
Right. Please put in key in the answers. Is it Alexander McBean? Is it Samuel Soley? Is it Sarah Newberry? Is it William McIntyre? I request all the other faculty to not answer it. There are students who are answering it. 30 seconds has started. Right. Your second question. Based on which phase 2 trial was the phase 3 Aquila trial conducted? Now, this is your journal club article. Very often we sometimes ignore the preceding trials, but a very important phase 2 trial became the foundation for this phase 3 Aquila trial. Which trial was the phase 2 which gave rise to the Aquila trial? Very interesting names. One of it was actually mentioned by Pravas sir. I was thinking, oh my gosh, my question is going now. But if you have listened to the entire webinar, you should be able to crack it. All right, we will move to question number 3. Right. Which of the following statement is false with regard to the baseline characteristics in the Aquila trial? Which of the following statement is false with regard to the baseline characteristic? More than 50% had the IgG subtype. Medium time from diagnosis to randomization was less than 1 year. Majority of patients had 3 or more risk factors, and 40% of patients had high risk as per Mayo 2018. Which of the following is false? This question will really test the depth to which you have read these articles. Right, moving to the journal scan. Now, among the following, which was the most common cytogenetic abnormality which was detected by FISH among the 406 patients? Among the following, which was the most common cytogenetic abnormality which was detected by FISH among the 406 patients? Last question, slog over, time to hit for a 6, or you can get out bold. It's a very easy question. If you listen to that excellent presentation in Journal Scan, which was the most common myeloma defining event which happened in the high risk group? Was it bone lesions? Was it anemia? Was it renal failure? Or was it an alteration in the FLC ratios? Which was the most common myeloma defining event? Easiest question possibly of the quiz. But then on a full toss, you can either hit for a 6 or get out. Right. With that, we come to the end of the quiz. 5 questions. We have moved from T20 to T5. And which among you participants are feeling like Elon Musk in the photo now, feeling all pumped up, having got the answers right? Let's look at it. So the first question was Sarah Newberry, and this image is possibly a harrowing description of the multiple fractures in femur and humerus that she had. Again, very apt picture to also look at why you should possibly prevent progression from smoldering to multiple myeloma. Right, Sarah Newberry is the answer. Moving on to question number 2. This was the Centaurus trial, which looked at the activity of daratumumab as a single agent in smoldering myeloma. And there's a small clue in the photo. If you can see right at the bottom of the image, I put a photo of a centaur. That was to make sure how many of you are really attentive and look for clues. So the answer was Centaurus. Right. Question number 3. The answer is a majority of patients had actually less than 3 risk factors. So 80% had actually less than 3 risk factors. More than 3 risk factors was present in 20% of patients only. And the rest of the statements were true with regard to the baseline characteristics. Right. Question number 4. Deletion 13q or monosomy 13 was the most common cytogenetic abnormality along with trisomy that it was seen in the study of among 406 patients. Right, the last slide, who hit it for a 6, who got out? Bone lesions. As it was very vividly told in the Journal Scan, the most common myeloma defining event across all risk groups. This was a trick question. Across all risk groups was bone lesions. In the high risk group, the second most common was anemia with 34%. Right. So with that, we come to the end of this chapter of the Journal Club and the Journal Scan quiz. Again, thank you to the organizers for giving this opportunity. Over to Dr. Sumit and the organizers as usual to announce much awaited the winners.
Hello,
Either you can announce the name.
sir. Dr. Avinash Hota from NIMS Hyderabad.
Excellent. So that you sir will be very happy. Sir, panel comments.
Yeah, I think the full article as well as something like in Journal Watch also. I think both, especially this discussant, Dr. Panda really explained very nicely and with the introduction as well as the future directions also nicely. And thanks to Dr. Ajay, I think it's a hard time for him to, again, he's participated as well as discussed very nicely the pros and cons of this study as well as the future directions. And Dr. Mishra sir also from Amrita, they have discussed very nicely all the points, including this, what are the clinical trials and what are the future also. And the Journal Watch, Sumit and all the participants, thanks to the organizers of Image. And thank you, sir. Pankaj sir, last comment from you now.
I just want to wish and thank Dr. Ajay Nuka because we just messaged him yesterday only to be part of international faculty, and he agreed at a very short notice. So although he has to have another meeting at 6:30, so he has left. But since this webinar is recorded, so I just want to put it on the record that we are greatly thankful to Dr. Ajay Nuka from Emory University, who participated as an international faculty and gave his comments. And along with that, thanks to Pravas, thanks to Dr. Panda and Sadashivdu and Nitin and Sumit and Mice Ideas, Nirav and other team. Thank you to everybody.
you, sir. Thank you.
Good night, sir. Thank you.
Yeah. We'll see you next time.
Thank you, sir.